Remember, again, I'm like this. Pag finasteride, we do finasteride. I've seen our GP, IM patients giving it. Bakit? Di ba alam natin na tama pa talaga yung PSA? So sila binibigyan nila agad. Oh, taas ang PSA mo. Finasteride, finasteride. This is the only time that I will tell the patient, mali sila. Kasi nainis tayo, di ba? Why? Anong cause ng PSA rise? The word is cancer. Right? So, ang step back, kung hindi ka pwede mag-get finasteride because of direct consumption issues, you have your vital care. Will it work as well? There's still evidence, but not as good as your finasteride and finasteride. Okay? Can the PDE5 inhibitors help? And Tadalafil has the data, diba? It's a small class relaxer, but you have to get long term. And 5 milligrams is about 150 200. So, ganun din siya, diba? And it won't work as fast as your alpha blockers. Okay? And then surgical treatment. You have the whole thing here now. From your laser here, your whole news, your TRP. So, why do we treatment with drugs due to reduction of your symptoms, improve the lifestyle, reduce the risk of retention, and need for surgery by 60%. Malaking bagay yan. Remember, when you go out in the wide world, syempre you start your practice. I have seen patients who come in who have been cured at 45 years old. 45. Going over the data, maliit yung prostate gland niya, 40 grams. Were you retention? You know, knee-jerk reaction. Siyempre, we want to earn a living, but you have to find out if this patient really need it. Kasi talaga nakita namin yung side effects later on. And of course, it will also show what you have done. So, 60% retention, reduction retention, and 60% the need for revision surgery. But then again, going back, when you give your 5-year ride, finasteride to finasteride, what's the most that the prostate will shake? The most is 28-30%. That's the data. That's the data. GSK suppressed data, and I read that paper. It was a Nordic data. It said only 30% of women will respond to the 5-year ride. So you can imagine, if you have 100 people in the room, only 30% of them respond. So don't be afraid. Treat them medically. Bakuhan niyo pa siya. And then they will come back to you. Tell them, I can treat you medically, wala akong indication, let's do this. Be patient when you treat the patients. Be patient when you treat the patients. So they'll come back to you. Then they'll bring your barangay. Barangay knows that. So, we know about this. You all handled that. The thing is, this one's bad. Okay? So, there's hemorrhage expect you afterwards. So, when the patients come in, put in your catheter. Right? But then, when you put the catheter in, I probably will think that he probably will be better in the cystoscopy. Because if you put the catheter in, and then you give your alpha blocker for 3 days. Okay, studies from the abusing studies. 3 days, you take a catheter out, makawili siya. Afterwards, you do it in 6 months. So, the thing there is telling you before that, you know, you can do the retention, you can request to have a surgery, but if you don't want, let's try. Because the nice thing about patients is you can predict that will happen to them, and if it happens to them, you'll go back to you. Magaling yung doktor kasi sabi niya, nangyari sa akin, then he will remember you, because you have told them. The knee-jerk of most patients now, kailangan opera kita. Ay, dok, excuse me, ano sinabi mo? Opera kita. Pwede bang huwag mo na, gamot mo na. Then they will see second, third, fourth, fifth opinions. So be patient. Explain to them, I can give you a alpha blocker, I can give you a muscarinic, your mechanical chloride, and hopefully you can urinate. But there's a big chance that mini-press or processing, and they give alpha blockers. Allographing function, and the rule of thumb is all blockers are the same. All blockers are the same, except for the side effects. But 10% of the patients, you have to worry about that. Even if you think, like for example, you're going to give the patient amphotericin, hard enough, and we know that the bad side effect is retrograde ejaculation, right? Because it keeps that blood level open. Remember, when we ejaculate, it's supposed to move forward, right? The glucocavernosus muscle is supposed to contract. So you move forward. The blood neck is slightly open, when you relax. So nawawala siya doon sa loob. That's the theory about that. That's the theory about that. So tell him about that before the dizziness, the retrograde ejaculation. But sometimes you can find that in acute symptoms. So the patients respond differently to this. But the data is there, the evidence is there, all of them are just about the same. Sometimes some people pwede ba ito ibang klaseng gamot for whatever reason, hindi siya niya, grabe yung side effect, or masyado mahal. So you have a whole gamut of medications to give, from European made to gaw-gaw. Ano yung gaw-gaw? Sino nakakalat ng gaw-gaw? It's the stiffener. From India. 5 pesos. Alpha blocker. Ano kaya ang kaplaman niya? Sugar? I have heard of comments. Bigyan natin na this drug. Sigurado yan. Hindi yan mag-improve. O, pero lang yan. Because one of the indications is failure of medical therapy. So you have to watch out for your alpha blockers. Okay? So we all know about that. And these are the guidelines from the EU. Just given out class. Hey! Kailan ba tayo sa TAR? Saan tayo? March sa EU. EA ba tayo sa March? So ito yung guidelines. To offer alpha blockers to men with moderate spirits. So, it's about 1A. The recommendations A. Okay? And counsel patients about treatment-related side effects. Selective versus outcome. So 1A and A. So good recommendation. So you have to watch out for this now. So remember your side effects. Lalabas yan sa boards nyo. Lalabas yan sa boards nyo. They'll try to trick you about that. So, you have to remember now that the rule of thumb is the smaller the prostate gland, the higher the smooth muscle content, the better the response to your abdomen. In real life, it should work in 12 or 48 hours. Okay? Your evaluation should be, for me, in a month. If the patient is in retention, wala siyang complication, I will give the alpha blocker, then it will come back in a month. In the past, nobody believed that post-coital residual is a good parameter of response. Now they're looking at it as a good parameter of response. So, you have to remember that when you're relieving the obstruction, you're actually helping the bladder contract better. But you're not treating the prostate gland. Screw the prostate gland, you're helping the bladder contract. That's why in patients with diabetes, you also sometimes have to give your muscarinic para mas malakas siya. So you open up the bladder, neck, so that the bladder, the loose muscle can contract better. Okay? So remember that. So after a month, babalik siya, ultrasound. If it's not working, ask why. Take the medicine. Well, like pa, nag-shift na mata, gaw-gaw, hindi natin siya po. Okay? And that's the rule now. So, 30 grams. 30 grams. Okay? We will split hairs, but if the board will ask a question, what is the evidence that will tell us that we need to give a 5-year life? That's 40. See how it's evidence. Okay, that's the evidence. Alpha blockers, IPSS, improvement, few months, improvement, on the action days, 24-48 hours. know that it will improve or reduce the size of the prostate gland. It's totally wrong. That's why, hello, when your friends take notes and mo, anong ginagawa nyo? Anong ginagawa nyo? Okay? So the long-term risk increases over time. So what are response rates or points? Defined as subject improvement of 25% versus placebo, and in most studies, the improvement will be only 30 to 40% compared to your TRP. So you can see a difference. Is there a road now of telling the patient, kailangan mo ng PUR? 120 grammer. Obviously, if you look at the data, 120 grams, kung limit man siya, 30% maging 80 grams. At 80 grams, kaya ba niya humingi? Kaya ba ng blato niya ilabas ng humingi? Not as much. Of the 110, 30% na ang mag-respond. Not as much. So all treatments, I would say, llamado tayo. Ang advantage sa atin. Just take care of your patients very well. Okay? Now, very important also to understand this. So when anyway, INS improves X%, we've known that all over. The efficacy is maintained long term. However, this is the caveat. Remember, especially in larger, 30 grams, 40 grams, okay lang yan. But raw-born clearly states, 30 grams is what we have to watch out for. Bakit? Ito yung mga prostate gland na lumalaki in the long run. 30 grams and more. So if you come inside, if the patient comes inside and 30 grams siya, the data from GSK tells us, kung 30 grams, ito yung kapatid, kung gusto stored in progress. And by progress is, if you look at the data, ito yung placebo line. These are all the events that will happen over time. 5 years. So kung bigyan mo yung pasyente na may 50 grams at alpha blocker na, in the long run, this random study, he will have an event. Placebo, look at this, all the events are there, then they will cross. That means to say, over time, your larger prostate gland, more than 30 grams, will increase in size, and then you have the event. So it is particularly wrong with an alpha blocker only in a prostate gland that you know will enlarge the long run. So keep that at the back of your minds. Anything 30 grams and less, no data, alpha blocker. Anything 30 grams and more, ito yung magpo-progress. At probably 40, I will give 30 grams, now will be that. The 30 and 40 grams, I will tell the patient come back in 6 months. So you can evaluate the patient better. Right? So if you look at this, comparing your alpha blocker and your 5-ARI, the 5-ARIs have lesser events, acute potential, into surgery over a long period of time. Can you keep the patients on long-term 5-ARIs? Yes. The data there is 4 years, but you've seen them continue for years. The patient will tell you, look, pwede ko ba titigil? Intermittent 5-ARI, no data. But real life, 6 months, lumita siya, 30 grams, balik ka after 6 months. Evaluate with ultrasound yung ulit. Kung hindi siya na-progress, balik pa rin. Sige. No medications, come back after 6 months. Pero within 6 months, lumati siya to 40 grams, you reinstitute the medication. You can reinstitute the medication. Tolerability of the alpha blockers, asthenia, anapnea, dizziness, orthostatic hypotension, with atherosclerosis, we all know that your IVs, intraoperative floppy iris syndrome, very important if the patients will be on or will have cataract surgery. Remember, your iris is just your pupil, your iris, and then your lens behind. So what happens now, if the smooth muscle of your iris will relax, it will close, it will constrict the pupil and hirap yung ophthalmologist mag-extract ng lens. They keep on dilating it, yung pala may alpha blocker ka, which will constrict that. It's the opposite effect of that. So it will constrict the pupil because your iris will relax. Muscle check, relax. So it will become smaller. So hirap sila mag-extract ng lead. So you just have to be aware of that. Treatment should not finish it before tract surgery, but a week after you can start the lead. So very important. Okay. Male and female, the same. Remember, sometimes you give your alpha blockers in blood contracture, right? And if they will go undergo cataract surgery, they'll be in a situation. So what do guidelines say for primary rights? Again, the IPSS is there. Reduction, the Qmax is not as much, but it's significant too. Onset fraction 6 to 12 months. The EU guideline 6 to 12. Evaluate, that's right. In the evaluation of your prostate gland, at least 6 months. Sayang, at most 1 year. If you want the patient to come back more frequently, 3, 6, 12. At least 6 months for the prostate. But for post-coital residual response to alpha blocker, a month. I want to see 6 months. Okay? Duration of FXA, years, and the risk of reduction is within 60 to 70%. Adverse events like omastia, reduced libido, erectile dysfunction, probably 5 to 7%. Less common erectile disorder. But these are things you have to tell the patient. Remember, when you talk about erectile dysfunction, on patients with 5 ARI, sometimes in about 10% of this 5%, hindi na bumabalik yung erections nila. But that data was also surprising. But we've known that for the last 8 years. So when we tell the patient, bibigay kami ng gamot, para hopefully yung prostate gland, ito yung side effect mo, sometimes hindi na bumabalik, kaya nyo bayan, tanggapin. Kung sasabihin ng pasyente, Dok, ay hindi pwede yan. I have still a 20-year-old wife na parang monkey na maliksing, na hanging on the walls, etc. Habulin ko siya. Then you have your phytotherapy. Diba? You have phytotherapy. These were recommendations made in 2012, and I believe these are 2017 recommendations. Very stark. They streamlined it, but look at that. They had 40 grams already there, and the combination again 40 grams there. And combination treatment is not recommended for short-term treatment. So 1 year is not the AKA. These were the 2012 guidelines. The 2017, 5 years should be offered to men with multiple groups, image prostate 140, and then consultations about the relative improvement with 5 ARIs. Nothing was said about how long nothing was said about how long you will give that. So now it's all up to us. It's all up to you to determine how much you will give and how long you will give. But since you know the actions, the patients can be kept down for years or whatever. Nasa inyo yan. So, these are the recommendations. You know about that, and these are the recommendations for your combination therapy. So, the rule of thumb is smaller prostate gland, ang blocker. May loops siya. Large prostate gland, 50 grams. Walang loops, 5 ARI lang. But loops plus your enlarged prostate gland, you give a combination. Simple lang yan. So, consider combination because you know that your prostate provides smooth muscles and then your prostate glands will respond to your 5 ARI. Again, the fast action of the 5 ARI, of the blockers is followed by a slow onset action of the 5 ARI. So, 1 year. Data, 1 year. Evaluation, 6 months to 1 year. Recommendations are there. Again, you'll hear 40 grams. The Roarborn study, again, 30 grams na siya to start the medication. So, that being said, let me segue now to your overactive bladder incontinence experience, of which you know, solid and obese very soon. I will try and when you were at TSS, you ever experienced urgency? Not naman tayo eh. In our young age, it's probably because of cystitis. And that's a fact. Okay? In the olden days, you used to look at urgency as problema talaga yan. But now, it has come to a point that when you look at your good symptoms, especially urgency and your overactive bladder, there are myriad of factors that can give rise to this. So dapat huwag tayong patakot. Kailangan lang natin iintindihan kung ano talaga siya. Because it's easily treated but frustrating. Kasi pabalik-balik siya eh. Not only for your patients, they will feel frustrated. It's a chronic problem already. Data that came out in the last AU, they're looking at a myriad of medications that are responsible for your OAD or for your urgency. So, we know about urgency and we know about urgent incontinence. So, if you look going back now to your fun or for your irritating or your storage symptoms, they are actually components of your overactive bladder. So, it's not a hard thing for us to understand where the LUTs, the storage symptoms come from. Kasi integral na yan sa atin. At naiintindihan natin yan. So the frequency is there, your urgency is there, and then the notorious there, and of course your incontinence. So kasama talaga yan sa LUTs natin. So you can see now why when we grow older, there's that urgency symptom. So it's part and parcel of our getting old. In fact, small prostate gland, smaller capacity bladder, pag umingi sila ng mabilis and the bladder fills up, jiggle yan kagad. And the moment that blood is stretched, the moment the blood is stretched, it triggers the receptors there na gusto lang bibig kagad. So, these are things that you will understand. It's a chronic condition. This was the data that came out last sa London. Okay? So, it's a chronic progressive condition. Remember, the bladders are getting smaller. Even females have that. But not as bad as the males. Not as bad as the males. OID, particularly urgent incontinence, will progress over time. It will persist. Kaya, very important for you to tell the patient na mangyayari yan sa'yo, it will keep coming back, pag nag-resolve, babalik ulit. Patient with prostatitis, it will worsen, treat nyo, 1 month, okay, babalik naman siya because of the chronic prostatitis. So, very important for you to understand. Over the years, the prevalence is there, especially in men. Why? We have the prostate gland that affects the bladder so much. Why? A lot of studies have told us your diabetes also affects a problem. Boss, ano yan? Ano yan? Bakakin yan. Anong? Bios lang po, sir. Ha? Bios. Anong plate number? UOF? Bios? UOF? Na? Nobody? Baka isa sa labas? Sige, sir. Okay. Alam ko only question. Hindi, siya doon pa-recollection. So, degree of bother will be increased with the frequency of the urgency and the urgent incontinence. So, as you grow older, ito yung mga mangyayari sa akin. Young patients, no problem. Older patients, yes, you have to watch out for that. But it is manageable. Now, this is something you have to get a picture of and understand. Because these are the drugs that will tell us how to manage bladder problems. Okay, first, you have your acetylcholine. Okay, meron siyang receptors which will, when it goes there and stimulate the bladder, will make it contract. have, okay, muscarinic receptors. Okay, your acetylcholine. That's why if you give your anti-muscarinic, your sulfenylcinate, your tolterodine, your esoterodine, your oxybutyrate hydrochloride, it will block this, and then it will relax the muscle. Right? And then also, you have to understand that we have your alpha-1 receptors here that are responsible for your contraction. That's why when you give your alpha blocker, this will relax and you'll be able to void. Females, the same. Your blood next full of alpha receptors. When you block them, you will relax, you can be able to urinate. And the last one will be your B3 agonists. Then your B3 receptors here in your detrusor muscle, which when stimulated, will relax your detrusor muscle. So that's probably one of the things that are coming out in the market, your Mirapecro, which will relax your smooth muscle, which is a different way of, aside from your anti-muscarinic to relaxing muscles.
Yay!
Your OAB, young women, both sexes, UTI and permanent pause, and you have diabetes, and then sometimes even the thought of wanting to urinate, even the thought of knowing malapit na yung banyo will cause the bladder contract. Why? You don't know. That's the mere stimulation by the thought will make the bladder contract. That's why some gentlemen, older gentlemen, 60, 70, mas lalo meron sa times, ako, putunin sa banyo ka agad. Later on, when you're older, and when you go on the trips with the urologists, kitang-kita mo yung mga older urologists o magtulad niya ng bus, pagbaba ng bus, banyo-bagan. Or bago umalis for trip na nyo, banyo-bagan, bago mag-bus. Kasi alam na alam natin yan. But the problem is, when you do this, you reduce capacity of your bladder. Remember, the bladder will expand, and then when it's good, it will contract. But when you intentionally void, you lose the contractile power. Kasi hindi siya nasa-stretch, di ba? So these are things you have to watch out for. Dapat comfortable full ka, baka mag-weak. Pero yung problem is, don't back in the time of voiding, the bladder doesn't expand. Talagang in due time, dinilid yung capacity. So these are things you have to watch out for. Okay? We know how to differentiate naman yung urge incontinence sa stress, urinary incontinence. Trigger by certain factors event. Running water will trigger that. Walking too cold, even cold itself, you front the aircon, not by two ways. Number one, when you're in front of that, it will increase the GFRs. Right? So, blood flow increases to your kidneys, urine is extracted, it will fill up the blood, and you will up. But cold by itself can stimulate your kidney. Okay? And then, going from a sitting to standing position, that movement will induce the bladder to contract. That's why sometimes you do your tapping, or you change the temperatures of over the superficial air, di ba? Hot and cold kayo. Actually, the problem doesn't really work. So, standing for that. And then the driveway, kasi alam ko, ang malapit yung bagyo. So, automatic, ganun ka, ayaw kumikibig. At night, very important to. Foot in the floor syndrome. Why? As I told you earlier, the man has to urinate, elderly gentleman, 3 hours or 4 hours. So when the time will come, pag-gising niya, puno yung pagpupo, kailangan po sa banyo. The moment he starts walking, drip, 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 kasi nag-contract yung bladder. And at night, mind you, these patients are not fully awake. Problem dyan is fracture. And there's been data to tell us that if this happens at night, about 15 to 20% of them will have fractures. So you have to control the symptoms so that they don't end up having fractures. And fractures in the elderly, regardless of the age, necessitates surgery. Fractures, whatever, iwan yung fracture, 6 months. Then, depression, pneumonia. So you have to watch out about that. So, foot in the floor syndrome at night is very important. Because the patients are so affected. you have to learn to control those symptoms. That's where your bladder acid comes. Diagnosis, again, history, and then you have your dehydration, I call it drip, retention, urinary retention, restricted mobility, infection, inflammation. So these are all the conditions that can give rise to your overactive bladder, your FUD, especially urgency. Now, again, the data in the past didn't tell us much about post-void residuals. But now we know patients with overactive bladder have small capacity bladder. And at the same time, wala sila residual. Very important also because the data also tells us that we don't give an antimuscarinic in patients with 150 ml residual. That's the data, right? That's the data. Because they will go into retention, because it's supposed to relax. But here, in the when you do your post-void residuals in patients who you know avoid symptoms, dapat zero residual. Then it's much more safe to give them an antimuscarinic and relax that down. Okay? So, in contrast distinction to patients that elevated PR, wag kayo magbigay ng muscarinic, ng antimuscarinic kasi talaga you're going to retention. So, medical treatment, etc. Significant overall treatment, failure of getting empty, recurrent ARS. Don't give the antimuscarinic. So in the evaluation of patients with your OAB, and your urgency and your urgent confidence, you look always at your residual. Because if your residual is less, nahulog ba yun? If the residual is less and you have a small capacity bladder, it's factor na yun. Diabetic patients, huge bladders, lots of residual. Huwag kayo magbigay ng antimuscarinic. Mabibigyan mo, methylene chloride, and then put that up the bladder. Usually, last lang the remember the bladder that's diabetic, hindi niya nararamdaman ang tunog. And when you do ultrasound, right, baby? Bladders that are diabetic, so diabetic, the residuals are so high. Treatment options. So, again, knee-jerk reaction. So, parang mo, bigla lang akong iihi. Okay? Knee-jerk reaction natin, okay, bigyan kita gano'n. Make the patient understand what's the cause of his problem. Because if he understands the cause of his problem, it's easier for you to treat. Kasi pabalik-balik, we know it's a chronic problem, we know it's got to progress. So if you want the patient to come back to you later on, right from the start, telling, hanapin natin yung cause, treat natin yung cause, kasi ito, result lang yan ang problema natin. So look for that cause, okay? So, patient education is important. Understand the cause of the OAB treatment. The treatment may not be 100% public. Remember, as I told you earlier, if you tell the patient what's going to happen, and if it's happened, you have these balls for the rest of his life. Technically speaking. Okay? Conservative therapy, lifestyle interventions, no coffee, no alcohol at night. Remember, meron silang mga diuretics, anti-hypertensive. So these are things you have to explain to them also. Pelvic floor muscle rehabilitation. Why? When you do Kegels, Manjo, alam mo paano Kegels? Do you know how Kegels feels like? Kinikegel ka ba? Okay. Why? When you contract your pelvic floor in your muscles, you prevent your bladder from contracting. Why? As I mentioned earlier, in your prostatic urethra, that's why di ba pag nag-void tayo, just before you void, that prostatic urethra or the bladder will open up. Right? Diba? That's why you feel some urine going down. And then, when it goes down, there are receptors there that will tell you that by feedback into your bladder, sumalabas ng urine, I need to contract. Diabetic patients, wala yan. When you do your Kegels, you tighten it up. Those receptors respond. And then it will affect the bladder also. So it will relax. It will relax also the bladder by emptying. So these are some of your techniques that you do so that you can increase the bladder capacity. You tell the patient, oh, kung gijingle ka or you have these urgency episodes in 3 hours, when the third hour comes, intentionally pigil mo. Wait, 10 minutes, bibig ka. The next time it happens, yung 10 minutes ng pigil, you make it 20 minutes. So what you're trying to do now is train the mind and the body to make the bladder capacity more. Okay? Then you depart from the treatment and then you serve. Treatment. So for nocturnal polyuria, fluid restriction, take your diet in the afternoon, compress statins, like elevation of brain. Then you have time for prompted voiding to prevent anemic contraction. So, kung sasabihin po siya, Dok, alam mo, I have to go back to every years. Bakit? Kasi hindi ko makontrol, talagang darating siya din. Every 2 hours magbibig ka. Or, rehabilitate at that, or pigil mo ang third hour. Then, pigil mo 15 minutes. Pigil mo talaga. Then, the next time happens, 30 minutes. So, you expand the times, you make the times long. Okay. 50% in constant action is founded by avoiding electronic errors. So you can teach the bladders to respond. Okay. However, if you just do that, the response is 57%. But if you give them an anti-muscarinic like sulfentazine or your best schedule, it will be better. Your response is better. So you give the drug so that the person will respond to that, while you train the bladder to relax. Fluid intake limitation, 1.5 liters per day. And now, ito dapat kailangan natin intindihan. Even for non-OIP patients, elderly gentlemen, pag uminom sila, talagang bibigyan. Diba? Tama, kasi tayo, young patient, sa young patient, we do that. It's a normal physiological reaction. Men with prostate problems, blood problems, pag nag-use ayaw na kasi, bilis na tumibig. Diba? So, major reaction nila, hindi iinom ng tubig. But it will cause 2 things. First, the bladder will be, the urine will be more concentrated. And the highly concentrated urine is irritated to the bladder. So, the more magkaroon siya ng urge, urgency symptoms. So I tell the patient, look, kung malapit ang banyo, inom ka ng tubig. It's better for you to be well hydrated. The bladder will expand. If you treat your bladder, if you teach your bladder to expand. Better pa yan, rather concentrated. That's why tayo, pag mag-opera tayo, hindi tayo inom. Paglabas, we will be concentrated, di ba? Then the next time, in 2-3 hours, we will run, mas mahirap. So, remember that the concentrated urine, kung hindi tayo inom ng tubig, tell your patients, you will be irritated, and will give rise to your body at the same time. Okay? Patients should reduce intake of blood irritants, again, caffeine, alcohol, and carbon beverages. Weight loss for all your patients. Remember, in constipated patients, this can happen also. By mechanical compression of the rectum up the prostate and the bladder, that can happen. The mere fact that you have lots of E. coli there because of your constipation can happen. So you have also to treat this constipation. Bladder training designed to increase time interval within voids in order to establish normal frequency and increase bladder storage capacity. So if it hold minutes to hours. Components, well-determined understanding or patient to understand that kailangan natin gawin because you will respond better. And then, urgency control strategies. Distraction and relaxation. Ginagawa iba yung distraction and relaxation during a sexual urgency episode. Okay? So, if he wants to avoid may urgency siya ngayon, then distract. Go think about something. Go somewhere else. Bago siya mag-avoid. And then, avoiding diet. Again, not pharmacological path, pelvic floor rehabilitation exercises, Kegels, at least 10 10 times a day. Like, effective in women. So that can help. Again, but then again, when you're dealing with inflammation, look for the cause. Antibiotics, your supportive management will be your antimuscarinic. So, antimuscarinics are currently the treatment of choice for you. So, what will happen now? When you give your anticholinergic, remember the drawing you had a while back? You have your acetylcholine and your muscarinic receptor. When you give your antimuscarinic, it's a blocker. It will relax that prostate, that bladder. It will increase bladder storage capacity and control those urgency episodes. So, when you're giving them education treatment, behavioral treatment, you give the drug because it will act immediately. So, the aim in adherence to therapy in early stages of behavioral treatment by immediate symptomatic control. Sabayan agad. You teach them what to do, you tell them what to take. And what to take is most important kasi it will act immediately. And the patient will feel better afterwards. Anticholinergics are still pillar in treatment of OA. This is data from the guidelines last year. All formulations provide a better rate of improvement of UUI compared to placebo. One recommendation, grade offer relief and extended formulations of antimuscarinic drugs for adults with urge urinary incontinence. So that's the recommendation there. You have to find the balance between adverse events and the overall efficacy. So you can see now the drugs are here, right concentrated in the midline. And more effective, you can see solvency 10 mg is here. So good shot with the less of the side effects. Okay. So here you have your oxybutylene, your factor on this side, more on adverse events. Take a picture if you want. You know that. Initial dose, 10 minutes sufficient, so you can see, but then they almost always respond. So now you're looking at your OAB symptoms, number of micturations, and the episodes of UUI. Bladder. So we ask ourselves the question: are these the only anti-cholinergics in the market, or those that have anticholinergic properties? And you'll be surprised to know that there are a lot of drugs in the market that have these properties also. So, chronic use of anticholinergic, let's say what kind of drug can give rise to a number of problems. Okay? And one of them was the dementia. So these are the drugs. You can see, cimetidine, prednisolone, theophylline. Remember, in patients with lung problems, cross-view. So when the pulmonologists give this to the patients with lung problems, in hopes of relaxing their bronchioles, it can also relax the bladder. So take care. Because these drugs also have anti-cholinergic properties that can affect the bladder. Okay? So take that into consideration. And my wife and I have argued over this position. Meron siyang, diba, Manjo? Meron siyang lung problem, o bibigyan mo ng ganito, can that cause, if I take my kahit out, you'll be able to do it, so I tell change into something that will not affect my bladder. So these are the drugs that can also affect your bladder. We make a decision of consider the patient's age, sex, comorbidities, symptom burden, and the personalized perception of these. Look, ayaw mo medicine, wala akong pera, or behavioral treatment. But then tell them again, you need that drug for the immediate effect. And later on, we can pay for it off. Consider polypharmacy and atomic drugs. Okay? And the need to avoid drugs with high anti-cholinergic burdens, especially older patients. So, if you look at this now, filling phase, your storage, and then the boiling phase. Your pressure system. You can use your antimuscarinic drugs anywhere, right? But if you look at this, saan yung dehado tayo? Where will it most not be good for us? Here, right? Kasi pag nagbigay ng antimuscarinic, hindi siya makawin maigi, di ba? So the therapeutic window of treating overactive bladder symptoms is here, in the feeling phase. When you can see, di ba, pag nag-urinary tayo, ito mo yung bladder niya, gumagano, kala mo, ako bibigyan nito. It's like you're waiting for the volcano to erupt and biglang mag-start na. Ubo! Ganun siya. So, this is where your antimuscarinic drugs will work. Okay? Afterwards, meron siyang effect on the contraction already. So, the drug has to be given because its nice effect is on the healing place. So we all know about our fun frequency respiratoria, and we all know about that the frequency of voidings will improve when you give your antimuscarinic compared to your placebo. So take for example, in easier terms, at night the patient voids 10 times with 4 or 5 urgency episodes, and including incontinence. When you give antimuscarinics, they will improve as much. Pagbalik nila sa'yo, oh, how are you right now? Ilang beses ka umihi sa gabi? Dok, naging 4 ka lang. Mas okay ba yan? Yes. Yung pagtulog nyo, yung pagkontrol, yung time na hindi kayo nagko-contract yung bladder na hindi kayo makakaabot sa banyo, lumalabas na. Dok, siguro once or twice. So, improve. So yung antimuscarinics will help patient manage the symptoms and the potential problems that occur with this pain. Guidelines, caution in men with bladder outlet obstruction. Okay, always check the post-void residual. Side effects of your muscarinic antagonists, your antimuscarinics: dry mouth, constipation. Dry mouth and constipation. Bakit dry mouth? Smooth muscle contraction, your blood flow into your salivary glands are much less. Dry mouth siya, whatever. Same thing with your constipation also. Okay? So smooth muscle does really affect. Increase of post-void residual and incident of urine retention compared to placebo. So you have to worry about that also. That's why the cutoff is 150 cc. 150 cc. Now, I will give you a scenario. Patient has loads, siguro mga 20 over 30 cups, significant. Wala siyang post, mayroon siyang mga 20% residual. The first thing probably you have to do is give the upper bladder in hopes that the bladder neck will open and then may labas yung bibig. So remember, meron siyang residual. The setting for cystitis is still there. Okay, meron siyang intravesical prostate protrusion by IPP. Okay? So, meron siyang urgency. Meron siyang residual. Pagbigay ng upper bladder, after 1 month comes back, wala na yung residual, pero meron pa rin siyang urgency episode. That's when you can give your sulfate instead of your antimuscarinic. Because the addition of your antimuscarinic can help control that bladder contraction. So it can help. How will you know? Number of episodes of micturations and your urgency episodes. Okay. So you can give the antimuscarinic with the upper bladder. Again, in your practice later on, titimplahin niyo yan eh. But it's wiser to start with the upper bladder, especially kung may residual siya. Kung wala siyang residual, and small bladder, and probably I will start with the antimuscarinic. It depends. But wiser, kung may residual, start off with the upper bladder, then you add your antimuscarinic. The recommendations: 1B grade B, antimuscarinics may be considered men with moderate severe roots or predominantly bladder sore symptoms. Okay? Prescribed antimuscarinics in men with the most caution in men with residuals of 150 ml. Recommendations: use the upper bladder with muscarinic in patients with moderate severe roots in relief of symptoms has been associated with monotherapy with either. So you say you can give an alpha blocker and then the antihistaminic, or with the antihistaminic and then give alpha blocker. But my rule of thumb is I'll start with alpha blocker and then give the antihistaminic. 150 chakra is the data, European data, but in the other data. Filipinos probably very much less. My threshold is about, I think if I remember right, we agreed with Joel and Dana 100 cc's. 100 cc's. Some data to tell you that the combination of your best care or your solvency with your OCAS will help patients who have LUTS and urinary incontinence. So the trials will just tell you that if you look at this, IPSS improve patients with solvency. Bakit siya 6? Raul, bakit siya 6? Raul. 6 siya dito sa data nila. Pero dito tayo 5, di ba? Best care natin 5. Pero dito pa sa data na 6. Ano yung European? So 6 sila? Parang made naman ng difference. So anyway, IPSS will improve and a mean change in total urgency and frequency score will improve. That's short of saying. Okay. Again, with your combination, it's close combination of solvency and your tox. Data, again IPSS, number of these iterations will improve if you give your combination always at two. Volume, is mean volume per iteration improve. Okay. So very important. Time out, constipation. Remember that. These are the things, two things in your antihistamines that will affect your patients. But not as much. 2.38% with your addition of your solvents. So your dry mouth and constipation very much so with your solvents in succeeding. Now, going back there. So we talked about your solvency, which is an antihistaminic, which will block the action of your acid protein that will make it relax. Now, inherently, the data, the new data, last 10 years, they'll tell us that there is another receptor called the beta-3 receptor that is responsible for your relaxation. So it's noradrenergic in nature. So what now? There is now in the market, so not yet approved here, a beta-3 agonist that will stimulate the receptor so that this will relax. And by and large of it is that for this drug, wala yung dry mouth, wala yung constipation. So that's the prime difference. The half-life is about 2 days. 50 hours. 50 hours for that. Okay. So way back, that is your beta-3 agonist. Mirabegron. In Europe, it's called that one. And it will activate your beta-3 receptors in the muscles that will give rise to relaxation and increase in blood pressure. So there are two already now. Your antimuscarinic, which is this, and your beta-3 agonist, which is the mirabegron. Again, its mode of action is mostly in this area. You know that these patients, when they are feeling, will have their urgency episodes, and that's where we work. It will relax your smooth muscle with activation between the BPA. The recommendation is there, 2017, that your beta-3 agonist is made with more severe roots who may have bladder, storage, or irritating symptoms. Again, the caveat here is your residual. Watch out, don't give it 150, but that's the data. That's the data, 156. It will reduce the number of uterations per 24 hours. So 1.5 to 2, 1.93. Sabi ko, hindi naman, parang busy ako every 3 hours, hirap naman yan. Kasi pagising niya, yung grade niya, kinigising din siya. O kailangan na maligo kayo. So, very important that one episode of urgency is very important for this elderly gentleman. Now, where is it most important? Is it in micturition or in the incontinence? If you look this forest cup and you consider this as the 0 point for your mirabegron. Less effective than mirabegron on the right side, more effective than mirabegron on the left side. So if you look at the drugs, look at this: doterotine, dariphenacin, fesoterodine, oxybutynin, all are less effective than your mirabegron in terms of controlling your incontinence. So your basic care is probably right here, which is probably better than your mirabegron. But then, why will you give your mirabegron if the patients don't like the climb out and the incontinence? So, if the patient wants the better efficacy for the incontinence of the episode, you probably are better with this one. Right? Micturition's number of fingers per 24 hours, mirabegron is here, not as good. Right? Probably you're better off with your solvency also. But then again, if they don't want the symptoms, you can always do that. Raul. Meron ba tayong data on the use of both? Wala, no? For solvency at saka mirabegron. Non-combined. Both at the same time? So I still have to do that. Cascade that. So, mirabegron, well tolerated, effective as an anti-muscarinic treatment, effective patients who discontinued other treatments compared to and it's well tolerated. Okay, so main side effects: hypertension and headache. Hypertension and headache. These are the two main side effects. Evidence. Well, we went to that a while back. Symptom improvement in elderly men compared to your top 10 rate is there in the eyes. So the number of episodes of incontinence improved compared to your doterotine and also compared to your placebo. Treatment according to the guidelines. In elderly people treated for incontinence, every effort should be made to employ non-pharmacological treatment first. Behavioral treatment, use fluids, take out the alcohol, take out the coffee, train them, kegels, increase blood fasting, time their voice. Very important. Okay? Long-term anti-muscarinic treatment, caution. Because they are at risk to have cognitive dysfunction, dementia. So these are things that they are seeing right now with the long-term treatment. Okay? Avoid total muscarinic load in older people with total drugs. So remember, there are other medications in the market that can have anticholinergic properties in the bladder. Especially in my practice, lung drugs. So ask your pulmonologist to review, or you can review it with them, because sometimes it can also affect the blood. Okay? Consider mirabegron in health patients. Traditional anti-muscarinic load is to be avoided kasi wala yung mga side effects of the other anticholinergics. Recommended. So, as we grow older, ladies and gentlemen, doesn't matter, you probably have these symptoms. The males earlier than the females. In females, cystitis, constipation, anabolic problems, etc., and bladder neck contractures. I'll show you one slide later. That I was very fortunate because Jim Balingin taught me that. And I was already a consultant. So you learn about these things from your consultant. Men have many causes for the loops, so it's not only your prostate gland, but there are other things, bladder stones, etc., stenosis, etc. These are the loops guidelines. The use of blockers, 30 grams and less. If the patient is symptomatic, always remember your loops will help 24-48 hours. Evaluate after 1 month. Get a residual load. Okay? Give your 5 alpha-reductase inhibitor if the prostate is 40 grams and more. Tell the patient of the side effects, erectile dysfunction, because a certain percentage of this will not recover anymore. So that's alam mo na yan. You can go back to your phytotherapy if the patients don't like 5-year rise. Combination is best when you have loops and a large prostate gland. We have done evaluation now is in 6 months. In 6 months. If the patient has, your indication for surgery, retention, recalcitrant, hematuria, renal insufficiency. So these are things that you have to tell the patient. But then again, these patients will respond, and then eventually they will fail. The thing is, keep them under your wing. Tell them to come back frequently. 6 months to 12 months, 6 months to 12 months. Tell them you're treating them. Tell them it's better that you have the medications because it will worsen. Kasi sometimes some people say, Doctor, pwede ba itigil? Yes, you may. But kung titigil mo ngayon, baka mas lumaki later on. So you have to keep them that para hindi na siya lumaki. So it's the way you tell the patient the consequences later on. The consequences later on. Okay? So your muscarinic receptor antagonist, if the patient has storage symptoms. So I probably will start with the alpha blocker in 1 month. If the patient is not improving, pero wala na siyang residual, then you can give the muscarinic. Okay, I think that was my last one. Thank you guys. Question?
Sir, which would you give first, the mirabegron or the solifenacin?
I think, well, number one, the mirabegron is like a year.
Okay.
Probably at the end of the year, probably here. So I'll start with I'll keep the alpha blocker, then add the solifenacin successor. Remember your anti-muscarinic is there, and it will really help. But check your residual first, check your prostate gland. Remember the bladder is the one that's reacting to a whole lot of problems. In the past, sabi na, prostate no problem, malaki prostate no problem. Hindi. It's the bladder. That's the focal point there. It's the one that's responding to whatever insinuation there is. Yung pinaka-pangit mangyari talaga sa inyo, diabetic bladder. Hirap yan.
How long will you give the solifenacin to say that it's
working?
Still working?
No data, but here you can go for weeks. 12 weeks. 12 weeks. Then you can taper it off. You can continue it. Remember, may mga problems with long-term treatment, di ba? So, remember, you're treating a symptom. You have to look for the cause. You have to look for the cause. Doesn't do justice to the patient. Bigyan ko lang ganito. Hindi, hanapin yung cause. So you put the patient off it. Babalik yung patient siya. Alam mo, mali yung doktor, bakit wala akong doktor ngayon? And I'm okay. So better to for the cause.
Usually, sir, when you give the patient solifenacin, the follow-up will be 3 months after.
Let him come back in a month. In a month. I used to evaluate earlier. For as long as you have contraindication to any surgery, treat the patient better. Then you come back after a month. Kita pa kayo. But the thing is, for you, explain to the patient. Gawin niyo yan sa OPD nyo. When you say patients, even if they're service patients, charge patients, after patients. Kasi later on, pag nag-graduate kayo, hanap mo kayo sa primary practice kasi kayo nagtulong sa kanila eh. Diba? Huwag nyo gugulat yung pasyente, surgery ka agad. Naku, ayaw niya agad. Remember now, ang kalaban natin, internet. Number one, ang kalaban natin, kamag-anak nasa abroad. May papadala na grapon na gamot. Kasi sabi ko, gano'n, may kamag-anak. So, you need to understand these things and you need to explain to the patient better. That is our best defense. The offense in telling the patient what he has, making him understand what he has, yung treatment plan, and then come back. Hindi yung, I've seen this pagdating na pasyente, ito yung mo. Look, saan to? Basta ano mo yan? Ayaw ng pasyente yan. Remember, patients now are wiser. They have the internet. To check din yung para saan ito? Ito ba pinigay sa akin ng doktor? So, tell yung patient, ibigay ko ito sa iyo because I want to feel this way, side effect niya ganito. And then, patients now, check din yan. Tama pala sa doktor. They come back to you, Dok, tama pala kayo. You got the patient book already for life. Including the kamag-anak. So practice in the OPD that one. Because whatever you will do in your OPD now will be what you will be when you practice it.
This brings us to every baseline policy, sir. Before we start with vital developments.
Always, rule of thumb, even if you treat the patient with the paracetamol, basta matanda, of course, if you treat the patient with, maski na alpha blocker, baseline yun, diba? Ano yan? AUA 55, diba? Sa atin, 50. Kung meron siyang history of prostate cancer, 40. Okay? So you need to get the baseline PSA. Need to get the baseline PSA. And then, kung mataas ang PSA, you worry, ano kaya to? Remember, volume, diba? Volume times 0.05 will give you a oxygen PSA, number one. Retention, tataas siya. Instrumentation, catheter, tataas siya. Right? Cancer, ejaculation, 48 hours, tell them not to ejaculate. Ejaculate wherever. Basta, do not ejaculate 48 hours before the extraction, otherwise the PSA will fall. That's very important. So get the baseline PSA. And then when you tell your colleagues, nako, takutin yung mga colleagues before you start them on anything, get a PSA. Get a PSA. Hey, looks so great today. Lahat naman ng ladies in the audience.